Welcome back this afternoon for today's Healthline 3. I'm Luana Munoz, and today we are welcoming a new face to the Healthline 3 family. This is Dr. Michael Banda. He is a general surgeon at Willis Knighton Health Systems in Bossier. Welcome aboard, Dr. Banda.
Thank you. I'm glad to be here.
Well, we are excited, of course, to have you. As I had just mentioned, for everyone who's watching, remember that you can always chime in, give us a call directly here to our studios, and you can ask Dr. Banda any question related to general surgery and how he might be able to help you out. So if you're watching, you can always watch online on ktbs.com or our digital channel 3.3. Also, if you don't want to call, if you don't want your voice heard over the airwaves, you can always submit your questions online as well. On the right hand side of your screen, you're going to see a Healthline 3 box there, and you can submit any question that you want for the doctor. So let's start off learning a little bit about who you are, Dr. Banda. Let the public know what it is that you do exactly and where you came from.
I'm a general surgeon, full-time board certified general surgeon here in Bossier City. I work exclusively at the Willis-Knighton Bossier Health Center, and I've been here for about 22 years. In the field of general surgery, we encounter many disease processes, especially processes that cause abdominal pain, and such as gallbladder disease, appendix disease, colon diseases, intestinal diseases, and stomach diseases. Also, we cover a variety of procedures involving the extremities, just external to the abdominal cavity.
All right, so tell me a little bit about when a patient should decide to go and see you. When should they seek treatment?
But more importantly, regarding abdominal pain, it's common that most of us get routine abdominal cramps, nausea, maybe a low-grade temperature. It could be from a virus, some food we ate that upset us. And when that abdominal pain gets worse, leaves the baseline of what we're used to, then I think it's really important for everyone to start considering calling their physician, and if it's more severe, perhaps going to an emergency room, a quick care. There's a convenient quick care in Willis-Knighton Hospital ER in every neighborhood and community nearby.
Can someone go directly to you, or do they need to be referred to you first by their physician?
Someone can come directly to me. Generally, we get referrals through other physicians, and quite often, if the matter is more urgent, we'll scoot around and make amends within our clinic schedule and get someone sooner if necessary. But certainly, anyone is welcome to call and make an appointment to get in to see us.
All right, and tell me a little bit about, as a general surgeon and performing elective and non-elective surgeries, do you do both?
Yes, I do. In general surgery, I would say half of our schedule is elective and half is urgent. On the elective side, we generally have patients seen in the clinic. I see every patient, sit down and discuss with them to see what their issues are, what their symptoms are, how long it's been going on, how it's different from the past. And certainly, if they come in with studies that have been done already, such as lab work, ultrasounds, x-rays, CAT scans, we'll certainly review all of those. In the office, I have my computer set linked up with the hospital system so I can pull up any x-rays or CAT scans or lab work that have been done prior. And optimally, what we do is when I talk to a patient, I'll know this information ahead of time. I'll examine each patient fully, and we'll discuss whatever the issue is at hand. Formulate a surgical plan, and if not as urgent, get them to schedule surgery at an appropriate time for them.
So is gallbladder disease typically one of the bigger diseases that you see or deal with?
It is one of the most common types of issues we see. Patients generally come in with perhaps pain in the right upper side of the abdomen. Sometimes that pain radiates around to the side, sometimes straight through to their abdomen like an arrow, or sometimes to their shoulder. I've had patients in the past that have come to the emergency room thinking they're having a heart attack. And after a full heart workup, turns out that it was their gallbladder all the time.
When it comes to treating them, what are some of the treatment options that you offer?
Nowadays, the preferred treatment and widespread modality is laparoscopic. Laparoscopic surgery is considered minimally invasive. Generally, a small 5 millimeter incision above the belly button, below the middle of the rib cage, maybe a 1 centimeter incision, and 2 5 millimeter incisions on the right side of the abdomen. For instance, in an elective setting, the surgery will generally take around 20 to 25 minutes. We visualize every aspect of the liver and gallbladder anatomy so that we can properly dissect out structures and remove the gallbladder. Interesting, some patients have gallstones, others never have any gallstones. In fact, I've seen patients who have come in and have had bad gallbladders and they have full gangrene of the gallbladder, not a single gallstone. So the big take-home message on gallbladder disease is that when one has these pains or symptoms and the workup is completed and the determination is that it's the gallbladder at the root of the problem, then it's probably best to go ahead and schedule surgery when convenient. These things generally, if they do get better, they can come back with a vengeance and create a bigger, more complicated issue.
All right, and laparoscopic surgery, once again, you mentioned that it's minimally invasive, so this is something that is a quick outpatient procedure?
Yes, indeed. Patients after surgery, they're in the recovery room for about 30 to 40 minutes, back in day surgery for another 30 minutes, and then home. Of course, we send patients home with the appropriate prescriptions and instructions, and certainly a return follow-up visit for an examination in the clinic. Certainly, if there's any issues beforehand, patients are always welcome to call or come by and to see if there's anything complicated prior to their regular visit.
You talked a little bit about gallbladder disease, but what about appendicitis? What's the difference and how can people tell?
Generally, gallbladder disease, and not always, but generally affects the upper parts of the abdomen, the upper mid-abdomen, right upper side of the abdomen. Now, appendix disease comes in all shapes and forms, but generally speaking, appendix disease or appendicitis, one can lose their appetite, one can develop nausea. Sometimes one starts off with a vague mid-abdominal pain. It kind of rolls around, and within a matter of 6 to 8 to 10 hours, that pain kind of migrates down to the right lower abdomen, where the pain becomes intense and sharp. At the slightest touch, patients can literally just jump off a chair from the pain. The reasons why some patients have more pain than others in the right lower abdomen because of appendicitis is the appendix can take many different positions. Generally, if the appendix is behind or situated behind the colon, then there's a cushion of the appendix having the colon in front of it before it touches the abdominal wall. Now, if the appendix is located on the front side of the colon, well, that inflamed appendix will touch the inner lining of the abdominal wall, which is very rich in neurological sensory fibers, and that would cause very intense pain. So when patients have these type of symptoms, and most of these patients come to the emergency room because it is that bad. If they don't call the EMS, they're in the emergency room, and generally the patients are seen in a timely fashion, routine lab work, a CAT scan, possibly an ultrasound, and once those results are reviewed, then the emergency room physicians will give us general surgeons a call, and we come down and we evaluate the patient in full, review the CAT scan, review the lab work, examine the patient thoroughly, and if our determination is it is an appendicitis, then we'll certainly notify the operating room team. They have rooms readily available, and straight to the operating room, and certainly the initial attempt is always minimally invasive or laparoscopic, and in this case with the appendicitis, we make a small incision, about 1 centimeter incision, above the upper edge of the belly button, a small 5 millimeter incision down below in the midline, and one on the left side. And even though we're on the left side of the abdomen, the laparoscopic instrumentation are rather long, 1.5 feet, so we're actually looking down towards the appendix from the other side of the abdomen. So basically, I position myself on the left side of the abdomen, and the appendicitis and process is going on in the right lower side of the abdomen. And so we're able to, with our advanced technology and imaging, laparoscopic equipment, we're able to visualize every little detail of the appendix. And once we identify every important structure associated with the appendix, we proceed to remove the appendix. We have state-of-the-art, what we call harmonic scalpel devices that cut and cauterize at the same time, and high technology endoscopic staplers, where we basically transect and staple the base of the appendix. And once we're done with that, we place the appendix into the surgical catch bag and remove it via the umbilical port site. And so upon the completion of that, we kind of scan around and look for any other issue that might be a problem, and we irrigate and suction out and basically clean the abdomen out. And on the way out, we'll close the incisions. We'll remove all these carbon dioxide that we use to fill the abdomen, close the incisions, and if there's no significant infection, then we'll close the incision with stitches underneath the skin that dissolve, and seal the incision with a liquid glue called Dermabond glue. And the value of that is patients are able to shower relatively soon after surgery without having to deal with a gauze or bandage getting moist and wet.
Well, it seems like when I was a little girl, everyone had some sort of an appendicitis. How far along would you say medicine has come in the last 30 years in terms of actually diagnosing them correctly? Because now I never hear about them as often, or we don't hear about it as much. But tell me a little bit about that and changes.
It's come a long way. Years ago, the routine approach to appendicitis was through a right lower abdominal wall incision. And with the advent of the CAT scan, the guessing has been minimized as to what the problem really was. And so once CAT scans technology became available, we certainly know with a high degree of certainty that the appendicitis is the issue at hand. And unlike the old incision in the right lower abdomen, which is very restrictive in a way, you can only visualize a certain area associated with that right lower abdomen. And certainly, if there's further infection, i.e. drainage from the appendix down into the deep pelvis, through a right lower incision, it'd be very difficult to kind of wash and suction all of that out. Now, with the minimally invasive laparoscopic approach, we can see a whole lot more than we normally could have in the past with a lower small abdominal incision. We can evaluate other structures, even structures up towards the north part of the abdomen, the stomach and spleen and liver and stomach. However, after the treatment, after we remove the appendix, we can kind of irrigate the area out. Any kind of turbid, infectious looking fluid, we can clear that out, suction it up, and basically when we're done with the operation, leave a very pristine, clean environment behind.
Well, let's talk a little bit now about COVID-19, Dr. Banda. Tell me what it's been like. Has your practice changed at all since the pandemic started?
It's changed certainly in terms of having to, as far as elective patients, they have to be, everyone gets COVID tested before going to the operating room. And so that process takes a few extra days because certainly we'd like to have the results back in a timely fashion. We would like to know, obviously, if the patient is COVID positive or COVID negative. And so that process has kind of been lengthened. However, when patients come in urgently through the emergency room or admitted to the hospital by a primary care physician, if they, for example, have a bad gallbladder, as we call cholecystitis or appendicitis, if these patients are COVID positive, well, we have a COVID ward that they're placed on. We have all the isolation protocols, masks, face shields, and when we do have a COVID patient, we will take them to surgery if they have the diagnosis of appendicitis or something more severe. They will be treated the same. However, we do take additional precautions. For example, in the operating room, just say if someone has appendicitis, well, we have smoke evacuator filters. We double up on a mask. We have our shields. We have hair covering. And the OR teams are very fluent at following these protocols. Everything does run smoothly, but it does slow the schedule down in terms of there's more preparation, there's more protocols to follow for safety measures that we all go through. And it's just part of the medical care delivered to these COVID positive patients. But nevertheless, it's all possible. It's all done in a very safe manner.
And it sounds like it, lots of precautions that you guys are taking there. Now, as you said, you have to perform elective as well as non-elective surgeries. Non-elective surgeries, it doesn't matter whether they are COVID negative or COVID positive. If you have to operate on a COVID positive patient, how does that make you feel? Is that a concern of yours?
It's no more of a concern than any other patient who might have a disease process. I've operated on patients who've had hepatitis C, AIDS, HIV in general, or any other infectious type baseline issues. So operating on a COVID positive patient, it does not concern me any more than any other patient I'm operating on. Even on a normal regular patient, we take standard precautions. And so we practice these standard procedures in every patient. And so when we do have a patient who's positive for some disease, COVID, et cetera, then as long as we're consistent in our protocols, and we're likely to maintain safety not only for the patient, but for ourselves as well. It does not bother me, does not concern me. I take my role as a physician very seriously, and I'm here to take care of the patient and do at the best of my ability. And I understand and do accept that there are potential future risks involved, but that's the role I take, and I accept it.
You're certainly dedicated to your work. How about your surgical team? How have they been able to adapt to COVID-19?
Initially, when the protocols and procedures come out, it was a learning curve. It was um, very detail oriented, but our surgical staff and supervisors have done a remarkable job of instructing and training and providing the protocol manuals to all of our personnel. Every personnel I work with takes their job and their protocol very seriously. I have not encountered any personnel who's afraid to take care of a COVID patient. And I think that comes from being comfortable with the safety measures and the fact that, patients are here for a reason. And despite their COVID positivity, we will take care of that surgical illness that they're here for.
Now, we know that a lot of people are not going into hospitals or not seeing their doctors regularly when they might really need medical care. How does this make you feel? Is this a big concern for you right now? And what message do you want to get out to the public for those who are fearful of COVID-19?
It is a concern, and I've seen early on when COVID back in March and April of 2020, when it really hit, and elective surgeries were shut down basically. It seemed like we would continue receiving patients who had the more urgent type surgical diseases, such as gallbladder disease, appendix disease, intestinal obstruction, or diverticulitis, which is inflammation of the colon. These type patients were somehow so fearful of the COVID environment that I have operated on several patients who were reluctant at coming and seeking medical care up until the time they got very severe and abdominal pain, illness. And what I've operated on in their situation was far more complex, far more intense and severe than it should have been had they shown up maybe 3 to 5 days a week earlier. So basically, what we all need to realize that if we have any kind of abdominal pain, symptoms that perhaps drag on more than 12 to 24 hours, something quite different than we're used to. And we all know our bodies well. And if it's gone past a certain point, by all means, despite what some hysteria about the COVID environment's all about, seek medical attention, call your physician's office, come to the emergency room, and try not to be as fearful, because the emergency room, we are taking plenty of steps at combating the COVID and following the protocol. So it is a very safe environment. But these issues need to be brought forward, because these surgical issues could get a lot worse and be a lot more devastating, therefore requiring a lot more recovery and downtime on patients.
All right. Well, obviously, it sounds like you said, your team is taking so many precautions right now to ensure the best medical care for the public, so people shouldn't be afraid right now. And I just want to remind the public again, if you're watching, you can call in and ask Dr. Banda any questions related to general surgery, elective and non-elective surgery. He covers both of those. So let's go back to a little bit about who you are. And some of the training that you received. I remember you saying you've had now over 20 years that you've been with Willis-Knighton.
Right. I've been here at Willis-Knighton Bossier for over 20 years. Prior to that, from 1991 through 1998, I did my general surgery training at LSU Health Science Center in Shreveport under the great and late John C. McDonald. During those years as a resident in surgery, there were many sleepless nights, long, extremely work days, 16, 24, 48 hours, you name it. We saw a wide variety of surgical issues such as trauma, any kind of penetrating trauma, gunshot wounds, stab wounds, or even blunt trauma from motor vehicle accidents. LSU Health Science has always been a level 1 trauma center, and so it's been a very busy time during training. We also did, as general surgery residents, multitudes of gallbladder surgeries, appendix surgeries, small intestine surgery, colon surgery for colon cancers and obstructions, stomach surgery for cancers or tumors, liver surgery, and have also participated in transplant surgery during that time as well. Of course, in general surgery, we always have the option of performing smaller procedures, such as removal of bodily tumors from the extremities, things of that nature.
LSU sounds like Drew Medical Center down in Los Angeles. You're definitely seeing a lot, which is good in terms for a physician learning. As you just mentioned, you're really being exposed to so much trauma and really learning how to work with the body. Now that you've been here and you've been doing this now for the last 22 years, I believe, at Willis-Knighton, you had mentioned, you know, what do you see? What message do you want to get out to the public today about the kind of care that you can provide to them?
Well, I'd like the public to know that whatever their surgical issue is, there's a Willis-Knighton hospital, health center in near every neighborhood of quick care. But specifically here at Willis-Knighton Bossier, we're a full service hospital. We have multi-specialties. We can operate on the most illest of patients. We have trained nurses and staff and critical care physicians that take care of the sickest in the ICUs. We're here, and it doesn't matter what time of day, what the weather is. This hospital is always fully staffed and ready to go on demand. From a general surgery standpoint, our general surgery practice offers 24/7, 7 days a week, 365 a year coverage. So whatever the public needs are from a surgical standpoint, and of course we have other surgical specialties as well. So we're equipped and full serviced, and the community can certainly depend on us to provide the care they need at any time.
And one final question for you, Dr. Banda. There's been a lot of disinformation, as you know, on the internet in terms of the COVID-19 vaccine. Some people are hesitant to actually get it. Have you received the vaccine, and what do you recommend for others?
Yes, I have received the vaccine, and I've received it from Willis-Knighton. They they have a really nice, efficient program, and that's flexible to our schedule and time. I consider the vaccine just like any other vaccine. It's all geared at building up your immune response, so that whenever your body does sense or sees a foreign antigen like COVID, then your response will be more brisk and upfront and basically more prepared. And being on the front lines of healthcare, I do take care of and operate on COVID positive patients, and I will without hesitancy. And so that's why I felt it was necessary for me to get the vaccine. I know there's a lot of opinions out there otherwise, but that's my opinion, and I believe it serves me well.
All right, Dr. Banda, I want to thank you so much for joining us today on Healthline 3. Hopefully it was just as enjoyable for you as it was for me. And of course, we are excited always to join new doctors here. Once again, this is Dr. Michael Banda with Willis-Knighton Bossier. He is a physician who has been in practice for many years. So please go call his office if you are experiencing any type of abdominal pain. Thank you so much, Dr. Banda.
Thank you. Thanks for having me.